Welcome back to the deep dive. We're here to take that dense, critical source material you need to know and really break it down. Today, it's the massive new ESVS 2024 Management Guidelines for Abdominal Aortoiliac Artery Aneurysms. But we're not just summarizing, we're doing a deep, critical audit of the evidence itself.
Exactly. Think of this less like a summary and more like a high-level viva. For you, our listener, we're examining the critical number, the evidence base, the real foundations. Our mission, get past the recommendation number and really appraise the quality of the data behind it, understand the nuances, and maybe more importantly, see where the gaps still are.
Yeah, and the sheer scale of this update. I mean, 160 recommendations, 59 completely new, 474 new references since just 2019. It screams rapid evolution.
It does, but as we're about to unpack, rapid evolution doesn't always mean level A certainty, does it? Far from it sometimes.
Right. So let's jump straight in. Let's talk about the foundational architecture of this guideline revision.
Okay, so diving into these huge guidelines, what was the really standout methodological limitation, the one the committee itself flagged about the evidence in the aortic field?
Well, you have to give the ESVS committee credit for being upfront about it, because the most, I guess, striking thing is just how, well, weak the overall evidence base still is. Despite all those new papers, they state very clearly that only 10 out of 160 recommendations, that's just 6%, actually have level A evidence behind them.
6%, wow.
6%. You know, the gold standard from top-tier RCTs or meta-analyses, it really hits home how tough it's been historically to run these big surgical trials.
So if only 6% is level A, what are we basing most decisions on? What level of evidence or maybe lack of it?
We're relying heavily on, well, experience. The vast majority, 112 recommendations, that's 70%, are based on level C evidence or just expert consensus.
70%.
Yeah, 7-0. And that's not just academic nitpicking, is it? I mean, 7 times out of 10, when you're counseling a patient or picking a device, it's coming down to expert opinion, not solid randomized data. The persistent knowledge gap. It means so much discussion is, well, consensus-driven.
And that reliance on consensus, it naturally brings in biases, gaps.
Yeah.
So which patient groups did they explicitly say are, critically underrepresented? And what does that mean for applying these guidelines everywhere?
They're very clear on this. The quote is something like, "The lion's share of available evidence relates to men of white ethnicity in highly developed socioeconomic societies." Now, they try to address sex differences. We'll definitely get into women later, but the recommendations for women often just have lower levels of evidence because they weren't in the big trials in the same numbers.
Right.
But beyond sex, they also highlight that other ethnicities, and really importantly, low and medium income countries, they're just not covered.
Yeah.
Essentially. So outside of, say, Western Europe or North America, the universal applicability of these 2024 guidelines, it's pretty limited.
Okay, let's pivot then. Let's talk AAA detection. That's got stronger evidence, particularly MASS, right? The guidelines talk population screening. What specific finding from the long-term MASS follow-up really changed things for surveillance of those subaneurysmal aortas?
This is where the long view really paid off. The MASS long-term data showed that initial screening protection, it started to fade after about 8 years. And the crucial bit, the real nugget, was that about half of the late ruptures, the ones happening 8 years or more after the screen, were in men who were initially called normal. But, and this is key, they had these subaneurysmal aortas, specifically in the 25-29 millimeter range, back at that first scan. It showed that a negative screen wasn't necessarily a safe forever screen.
That's huge. So if the risk lingers in that group, what's the current ESVS advice for men with aortas between, say, 25 and 44 millimeter? And how do they justify that 5-year surveillance interval without specific cost-effectiveness data for that group?
So, recommendation 13. It advises that these men should now be considered for ultrasound surveillance every 5 years. If their aorta is in that 25 to 44 millimeter range, the justification, it's a mix. They combine that MASS late rupture data with progression data from Swedish cohorts.
Okay.
The Swedish data showed that a pretty decent chunk, 30% of 65-year-olds with that subaneurysmal dilatation, actually hit the 55 millimeter repair threshold within 10 years. So a 5-year check. It's seen as safe, effective, justifiable. It catches those late progressors without overscreening everyone.
Right, makes sense. Now, thinking policy, this overall prevalence decline, what's the current number for AAA prevalence in 65-year-old men in the UK and Sweden? And what's driving that good news?
It's dropped sharply. It really is a public health win. The guidelines cite recent data, 2020, 2021, showing prevalence is now less than 1% in 65-year-old men in both the UK and Swedish programs.
What's the 1%? Down from 8.
Down from around 1.7 to 1.3% not too long ago. And the drivers are clear. Less smoking, much better cardiovascular risk management across the board. Now, that low prevalence does challenge the original cost-effectiveness models, but the guidelines still back screening because MASA showed that undeniable drop in AAA mortality.
Okay, before we leave screening, the measurement issue. This is critical. Can you define that controversy? Specifically the difference between ITI and OTO measurements and the huge numerical impact it has on who gets diagnosed.
Oh, it's a massive headache for standardization. The method you use, inner to inner, ITI, outer to outer, OTO, or leading edge to leading edge, LE, it fundamentally changes the number you get. But we know ITI, measuring just the lumen, gives you a diameter that's consistently about 3 to 6 millimeters smaller than OTO, which includes the wall.
Right, 3 to 6 mil difference.
Exactly. And the clinical impact is enormous. If a screening program just switches from ITI to OTO, the number of people diagnosed with an AAA, defined as 30 millimeters or more, jumps by 77%.
77%, just from changing how you measure.
Just from that. It dictates who gets labeled UPLA and enters surveillance for life. It absolutely screams for a universal standard, doesn't it?
It really does. Okay, let's put this into practice. Clinical scenario. Fit, 65-year-old guy, former smoker, comes for screening. First scan shows 28 millimeter measured ITI method, like many programs use. How do you counsel him? You need to blend the MMSS data with this new ESVS advice.
Okay, first step. Confirm that based on the official screening cutoff, his scan is technically normal. But I have to immediately clarify he's in that subaneurysmal group, 25-29 millimeter. Then I draw directly on MSS, explain that while his immediate risk is tiny, this group did account for those late ruptures. Therefore, citing recommendation 13 and the Swedish progression data showing late identification works, I'd strongly advise rescreening in 5 years. It's about tailoring that follow-up to manage the residual risk the long-term studies uncovered.
Nicely put.
So wrapping up this section, AAA screening's foundation is solid, yes, but the new evidence really forces us to nail down measurement standards and mandate that long-term watch on the whole subaneurysmal group.
Yeah.
Okay, moving on. Let's tackle what might be the most, compelling epidemiological finding in this update. The sex difference. What's the definitive number? The difference in rupture risk between men and women with small AAAs, according to that RESCAN meta-analysis. This feels like a number everyone just has to know.
Oh, absolutely. This number changes practice. It fundamentally impacts our thresholds. RESCAN nailed it down. Women have a 4-fold greater rupture risk across all AAA sizes compared to men.
4 times.
4 times. Let's make that real. A woman with a 50 millimeter AAA, her annual rupture rate was 2.97% per year, nearly 3%. Now, a man with the same 50 millimeter AAA, his risk was just 0.64% per year. That's the 4-fold difference right there. Stark.
Okay, so if the risk is 4 times higher, what's the critical implication for the diameter threshold? When should we even consider elective repair in women compared to that historical 55 millimeter mark for men?
It completely shifts the risk-benefit calculation, doesn't it? The data strongly suggests women hit that critical risk point. Let's call it the 1% annual risk we often talk about at a much smaller size. The guidelines mention that a 42 millimeter AAA in a woman carries roughly the same rupture risk as a 55 millimeter AAA in a man.
42 equals 55, risk-wise. Wow.
Exactly. And that stark reality led directly to the consensus recommendation. Consider repair closer to 50 millimeters for women, measured by ultrasound, not 55.
Which leads us to the new negative recommendation, the sort of fence post they've put in. What's that explicit new Class 3 recommendation about repair thresholds specifically for women?
Yeah, this is important. Recommendation 21. It's new, it's Class 3, based on consensus, and it states quite clearly, women with an asymptomatic AAA less than 50 millimeter are not recommended for elective repair. So while 50 millimeters is the point you start thinking about it, this negative recommendation sets a clear lower boundary. It tries to stop us intervening too early while still acknowledging that massive risk once women get above 50 millimeters.
Makes sense. But it's not just rupture risk, is it? There's the other side of the coin, operative mortality. What's the evidence say about that for women versus men, for both open and endo repair? Is it just anatomy or something else?
It's significantly higher for women, unfortunately. It really is a double-edged sword for them. The guidelines cite a key Cochrane review. It showed the odds ratio for 30-day or in-hospital death was higher in women compared to men. For OSR, the ORR was 1.49. For EVAR, it was even worse. They're 1.86.
Nearly double the odds of dying with EVAR for women.
Exactly. Nearly double. Now, anatomy, smaller vessels, trickier necks, that definitely plays a part. But it's likely compounded too. Women often present older with more comorbidities than men in the same AAA size group. It's probably a mix of factors. But that high EVAR-R, that's a massive point for counseling.
And this lack of definitive data, the reliance on observation and subgroup analyses. That's why the Warriors trial was launched, right? What critical question is that international RCT designed to finally answer about women in smaller AAAs?
Warriors is trying to plug that exact evidence gap. It's designed specifically to test whether women with those small asymptomatic AAAs, the ones below that current 50 mm consensus line, would actually benefit from being offered EVAR right away. If it delivers, Warriors could give us that level A evidence we desperately need to set a truly evidence-based threshold instead of relying on the current 50 mm consensus.
Okay, let's swing back to men for a second. We know the standard 55 mm threshold for considering repair in men got downgraded. It's classed high now. But what evidence keeps the negative recommendation, the class 3, against operating below 55 mm in men so strong?
The strength of that negative recommendation 20 class 3 level A is rock solid. And that distinction is crucial. It's backed by 4 absolute landmark RCTs. UKSAT, ATOM, CSER, Pivotal, all of them consistently robustly show that watching AAAs under 55 mm in men was incredibly safe. Annual rupture risks were tiny, 0.3 to 0.8%. So the guideline committee downgraded the positive recommendation at 55 mm because the trials only proved it's safe not to operate below 55 mm. They didn't prove you must operate at 55 mm. But the safety of watching below 55, that's absolutely level A.
Got it. Okay, practical challenge time. You've got a 70-year-old woman, 52 mm infrarenal AAA on ultrasound, otherwise fit. What specific data points, what unique challenges do you have to cover in that consent and shared decision-making process? You need to weave in both the rupture and the operative risk data.
Right, this needs really careful handling. SDM is absolutely key. First, I have to clearly explain her rupture risk. Use the REST scan data. She's over the 50 mm consensus threshold. Her annual risk is getting close to that 3% mark, way higher than a man's. But then immediately, I have to balance that urgency by explaining her higher operative mortality risk, especially that OR of 1.86 for EVAR compared to a man. Since she's just above that negative threshold of 50 mm Rec 21, repair is definitely on the table due to the rupture risk. But we have to factor in her fitness, Rec 22-25, and make absolutely sure she grasps the elevated risk of the intervention itself before deciding. It's her choice, informed by those numbers.
Okay, so to sum up this crucial section, women face this unique, tough situation, much higher rupture risk at smaller size, but also significantly higher operative risk. That area around 50 mm, it demands incredibly individualized, evidence-based, shared decision-making.
Okay, let's shift gears from epidemiology to, well, quality control, governance. Things the new guidelines really hammer home. Minimum caseloads for centers doing standard AAA repairs. What's the number? And how does volume link quantitatively to outcomes?
Yeah, volume is clearly linked to safety here, the recommendation. Minimum 30 standard AAA repairs a year for a center. And importantly, they specify a balance, at least 15 open, 15 endo. The why comes from meta-analysis data. It's compelling. Patients treated in low-volume centers, they had a statistically significantly higher perioperative mortality. The odds ratio was 1.39 compared to high-volume centers. That applies to both OSR and EVR.
Or 1.39 higher risk in low-volume center.
Exactly. It's a key benchmark for thinking about accreditation, service configuration, all that stuff.
And the guidelines use some strong language about device choice, sticking to the rules, specifically thinking about EVS, Nellix. What's the big lesson the 2024 guidelines are drawing from that whole saga regarding device selection and instructions for use, the IFU?
The Nellix story. Yeah, it's become the absolute textbook cautionary tale, hasn't it? It underlines why we need rigorous long-term data and strict adherence to protocol. The guidelines now have very clear, strong wording recommendation, 57, Class 3, advising against doing EV outside the manufacturer's IFU in the elective setting, period.
Class 3, not recommended.
Right. The lesson is, straying from the IFU isn't just a technical gamble. It carries real medico-legal weight, and as some reviews showed retrospectively, it was linked to higher overall mortality. We have to stick with devices that have proven long-term track records, not just shiny short-term results.
Can you outline the governance story there? The manufacturer's final move and what the ESVS committee advised for patients who already had Nellix implanted. This feels like a critical post-market surveillance failure example.
The path was, unfortunately, pretty clear by the end. Reports were mounting internationally unacceptable late failure rates, so the manufacturer, Endologix, stopped production in May 2022. Then ESVS stepped in with a focused update. It urged clinicians, find all your patients with Nellix implants, get them into enhanced surveillance programs immediately. And crucially, the advice for fit patients: if you do find device failure, consider early elective explantation. Don't wait for rupture. The risk is just too high with this specific device.
And what is Nellix failure? How is it different from just seeing a standard type I or type 2 endoleak like we see in conventional EVR? What's the mechanism?
This is the key distinction, and it's often misunderstood. It's about conceptual seal failure. It's not always a clear leak source you can pinpoint initially. Often the mechanism involves the device migrating caudally downwards. That leads to loss of the proximal seal or sometimes separation of the endobag components. This allows the sac to get pressurized again by pulsatile flow, and this is critical, it often happens without an obvious endoleak on standard imaging, at least initially.
So migration is the big warning sign, even without a leak.
Precisely. The reports confirmed higher than expected rates of eventual type 1A leaks, migration, and actual aneurysm rupture. It pointed to inherent design issues, especially when used outside that strict IFU. We need our follow-up teams looking for subtle migration, not just obvious leaks.
Okay, shifting to conventional EVR durability now. What's the enhanced surveillance requirement for the newer generation grafts, especially those low-profile ones? And what's the new minimum duration for that prospective registry data?
Yeah, the committee definitely took a cautious approach here, likely due to historical problems. They cite issues seen with some newer low-profile designs, like Zenith Alpha having a surprisingly high limb occlusion rate, 12.4% in one study, versus just 0.7% for Gore excluder. So to try and catch these things earlier, Recommendation 58 raises the bar. New devices, or even updated ones based on existing platforms, now need to show durability data for 10 years in prospective registries.
10 years, up from 5.
Up from 5. It's a clear signal they recognize midterm device problems are a major governance headache and patient safety issue.
Right. Let's apply this governance lens. Fit patient, 2.5 years post-Nellix EVAS. Sac size is stable, but the CT shows, a mild caudal migration of the proximal ceiling bits. No obvious endoleak on the standard CTA. What's the advice? Emphasize that enhanced surveillance in governance context.
Okay, this patient lands squarely in the high-risk category. We have to act. That migration, even if mild and even with a stable sac, signals potential conceptual seal failure. And we know Nellix failures often happen late, after 2 years. So, step 1. Immediate enhanced multimodal imaging, probably CEUS or maybe MRA if the CTA isn't showing a leak but you suspect seal compromise. Step 2, and this is crucial given the ESVS update, aggressive counseling about early elective explantation. Since the patient is fit, the balance of risk strongly favors getting the device out before it ruptures, rather than just watching and waiting given the known high late failure rate of this specific device.
Makes sense. Proactive rather than reactive for Nellix.
Exactly. So, wrapping up. Volume counts for safety, and the Nellix withdrawal hammers home the need for strict IFU adherence and that new, tougher 10-year durability surveillance standard for all new endovascular platforms. All right, let's tackle ruptured AAA, RAAA. Management here has seen arguably the biggest strategic shift in our field. What's the current Class I recommendation now for treatment strategy, and what's the evidence level supporting it?
The paradigm is definitely flipped. Recommendation 80 is now Class I, Level A. It states that endovascular repair, EVA, is recommended as the first-line treatment for patients with RA if they have suitable anatomy.
Class I, Level A for EVAR-First. That's definitive.
It is. It formalizes that EVAR-First strategy in centers that can deliver it, driven by the big RCTs and subsequent registry data.
Now, IMPROVE was foundational to this shift, but people often quibble about the main result of 30-day mortality and the overall intention to treat group. What were those key numbers again?
You're right. The ITT result caused a lot of discussion. Remember, in IMPROVE, randomization happened before they even got the CTA scan to check anatomy. In that ITT group, there was no statistically significant difference in 30-day mortality between the EVAR-First strategy, which came in at 35.4%, and the open repair strategy, 37.4%.
So basically the same mortality at 30 days in the ITT analysis.
Pretty much. But the key takeaway wasn't really that headline mortality number. It was the operational benefits of the EVAR-First pathway: less blood loss, less ICU time, and ultimately a cost advantage that showed up later on. And that was despite a large chunk, 36% of the patients randomized to EVR actually crossing over to open repair because their anatomy wasn't suitable once they got the scan.
Okay, so if the overall 30-day mortality wasn't that different, it makes the next finding incredibly important. What procedural factor, pulled out in post-hoc analyses of IMPROVE and other big registries, was linked to a huge survival improvement for RA-EVAR, and what was the mortality difference?
This is probably one of the most impactful findings. Doing the EVR under local anesthesia, LA. The post-hoc analyses were striking. A big meta-analysis over 4,300 patients showed EVR under LA had significantly lower perioperative mortality,
Hmm.
17.3%. Compare that to 26.4% mortality when they used general anesthesia.
Wow, 17.3 versus 26.4%. That's a massive difference.
It's huge, an absolute reduction of 9.1%. The odds ratio was 0.49. The thinking is you avoid the hemodynamic crash on induction with GA, avoid the positive pressure ventilation. It gives a profound survival advantage, especially if the patient's reasonably stable hemodynamically to start with.
Right, avoid the GA hit. Makes sense. Now, practically managing these patients. We use permissive hypotension, rush them to CT. What specific technical point about stent graft sizing do we absolutely have to remember if that pre-op scan was done while the patient was hypertensive?
Ah, yes, this is a critical technical detail. Ignore it, and you risk proximal seal failure later. If the patient was scanned while hypotensive, their aorta is vasoconstricted, right? So the scan will systematically underestimate the aorta's true diameter once you resuscitate them and their pressure comes up. Therefore, recommendation 76, class FIA, advises you should consider oversizing the stent graft by up to 30%. That compensates for the underestimation and helps ensure a good seal long term.
30% oversizing for hypotensive scans. Got it. Let's talk complications. Abdominal compartment syndrome, ACS. It's often fatal after RAA repair. Can you quantify that mortality penalty using registry data?
The prognosis just plummets if ACS develops. The Sweat-VATS registry data is chillingly clear. Patients who got ACS had way higher mortality at 30 days, 90 days, and 1 year. The numbers were 42.4%, 58.7%, and 60.7% mortality if you developed ACS.
Versus 23.5%, 27.2%, and 31.8% if you didn't. It more than doubles the risk at 90 days in a year. It just underlines why we have to be so vigilant about intra-abdominal pressure and act early if it climbs. Absolutely. Now, sometimes the patient is just too far gone. We have to consider futility. Is there a preoperative scoring system the guidelines mention as being practical for starting those difficult conversations about maybe not intervening? What variables does it use?
They mentioned the Harborview Medical Center score. Its strength of simplicity, especially in that chaotic emergency setting. It uses only 4 pre-op variables. Age over 76, pH under 7.2, creatinine over 2 milli-GDL. Any episode of really severe hypotension, like SBP under 70, you tally those up. And the guidelines stress this, you should never make a decision to withhold treatment based solely on a score. It's a tool to help structure thinking and communication with the family, not a replacement for clinical judgment.
Right. A tool, not a rule. Okay, time critical vignette. Patient comes in with RAAA, stable after initial fluids. CTA shows anatomy looks good for EV. You're planning EV under local anesthesia. What's your immediate plan for systemic anticoagulation? When do you give the heparin?
Okay, EVR under LA, stable patient. The key principle here is hemostasis first, so systemic heparin. You only consider giving that after the rupture bleeding is controlled, meaning after the main body of the graft is deployed and you've achieved proximal seal, that's recommendation 77, class 3A. Give heparin before the seal is achieved and you risk worsening the bleed, completely undoing the survival benefit you gained by using LA in the first place. Seal first, then heparin.
Got it. Seal first. Okay, so wrapping up, RAAA. The standard of care has evolved to EVAR-First, backed by level A data now, and that counterintuitive but clear mortality benefit with local anesthesia is huge, alongside those strict technical rules like the potential need for 30% oversizing.
Right. Let's move into the really complex territory now, juxtarenal perirenal disease. When we compare fenestrated EVAR, FEVAR to open surgical repair OSR for these tough juxtarenals, what's the consistent trade-off we see again and again in the observational studies and meta-analyses?
Yeah, this trade-off comes up constantly. It's basically early morbidity versus late durability and reintervention. That's the core dilemma. The network meta-analyses consistently show FEVAR wins early on. Significantly lower perioperative mortality, relative risk about 0.62. Fewer early complications too, like MI rate is much lower, RRR 0.37, compared to the big physiological hit of OSR.
Okay, so FEVAR looks better initially.
Initially, yes, but the price comes later. FEVAR consistently has a significantly higher rate of needing further procedures down the line, midterm reinterventions. One analysis put it at around 11.1% for FEVAR versus just 2.0% for OSR. The hazard ratio is about 1.65. That need for lifelong follow-up and potential redo is the downside.
And that leads us to some worrying new data, doesn't it? Can you talk about the preliminary findings from the UK COMPASS trial, specifically about long-term overall survival in standard-risk patients who got FEVAR versus OSR for juxtarenals with short necks, 5.9 millimeter?
Yeah, the UK COMPASS preliminary data. It definitely sent ripples, maybe even shockwaves, through the community. It's not fully published yet, needs peer review, but after about 3 years follow-up, median time, the overall mortality was reported as significantly higher after FEVAR 21.2% compared to OSR 7.5%. This was in standard risk patients with those short necks.
Higher overall death rate with fever in standard risk patients.
That's what the initial data suggests. Now, interestingly, the late aneurysm-related deaths were similar between the groups, which suggests, perhaps reassuringly for the tech itself, that this survival difference might not be fever failing per se.
It might be unrecognized confounding selection bias. Maybe the standard risk patients selected for FEVAR actually had hidden comorbidities that limited their overall lifespan compared to the truly fit OSR group. But it's definitely raised eyebrows.
Hugely. So given that COMPASS data, how do the guidelines frame that fundamental choice now? OSR versus FEVAR, or branched EVAR, fit versus frail patients with complex anatomy?
It really pushes towards even more individualized decision-making, doesn't it?
Yeah.
Reinforces the MDT role. OSR, especially if you can get the clamp and anastomosis below the renals, is positioned as the preferable, likely more durable option in fit patients, especially those with a long life expectancy and reasonable anatomy. But for patients with really complex anatomy or those who are high surgical risk because of comorbidities, then an endovascular solution, FEVAR or BVAR, is still justifiable. You accept the higher late reintervention risk in exchange for that proven lower early morbidity and mortality.
Right, tailored approach. What about alternatives? Parallel grafts, chimneys, Shivar? What's their current place in elective complex repair? What are the main limitations, and what's the maximum number of chimneys the guidelines suggest?
Chimneys are pretty much relegated now. The guidelines position Shivar really only as an option in the emergency setting or as a bailout if something goes wrong during another procedure. They are explicitly not preferred for elective complex repair. Why? The main issue is sealing. They have much higher rates of type IA endoleaks coming from the gutters between the chimney grafts and the main stent graft, about 7.6% leak rate versus 3.7% for FEVAR.
Double the gutter leak rate.
Roughly. It compromises the long-term durability. So the guideline restricts their use. Maximum of 2 or fewer chimneys, recommendation 122, class 2I. It underlines that this isn't a great primary sealing strategy.
Okay. And briefly touching on other complex aortic stuff,
Yeah.
uncomplicated type B aortic dissection and TEVAR, the guidelines stress minimizing aortic coverage. Why is that so important in planning these repairs?
Minimizing coverage is all about reducing the risk of the big neurological complication, spinal cord ischemia, SCI. Whether it's complex aneurysm repair or dissection, the more aorta you cover with stent graft, the more likely you are to sacrifice critical intercostal or lumbar arteries that feed the spinal cord. So while you absolutely must get a good proximal seal, the surgeon has to constantly balance that against the length of coverage. And use other strategies too. Keep the blood pressure up, preserve collaterals where possible, maybe even use CSF drainage sometimes to try and mitigate that SCI risk.
Right, always balancing seal zone against SCI risk. Okay, let's do a final complex vignette. You've got a 62-year-old patient, fit, non-smoker, has a 60-millimeter juxtarenal AAA, but the neck is really short, just 3 millimeter. He's active, expects to live another 20 years easily. How do you present the FEVAR versus OSR trade-offs? You need to really emphasize that durability and the emerging long-term survival data.
Okay, for this patient, young, fit, long life expectancy, but tricky anatomy, the conversation has got to be dominated by long-term durability. I'd start by acknowledging FEVAR's upfront advantage. Lower early complication rates, quicker recovery. Mention the meta-analysis data showing lower peri-op mortality. However, I'd immediately pivot to the downsides. I have to clearly state the significantly higher late reintervention rate with FEVAR, quote, that 11% bis into death, versus 2% figure, the HR 1.65. And then, critically, I have to introduce the preliminary UK COMPASS data. Explain that, in patients like him, standard risk, there's a worrying signal of potentially poor long-term overall survival with FEVAR, even if aneurysm-related deaths look similar. My conclusion for him would be, OSR, despite the bigger initial hit, represents the most durable, proven long-term solution. Given his fitness and lifespan expectations, should be strongly considered as the preferred option to maximize his long-term intervention-free survival, provided we deem his early operative risk acceptable after thorough workup.
Crystal clear. Okay, summing up complex AAA. It's this really delicate, highly personal balancing act, trading FEVAR's lower early morbidity against OSR's better long-term durability. And that balance is now being further complicated by this emerging concerning late survival data from trials like COMPASS. Well, that brings us to the end of a really detailed and I think necessary deep dive into the evidence underpinning the ESVS 2024 guidelines. We've hit some crucial numbers at 4 times higher rupture risk in women, the need for 10-year durability data for new devices.
Absolutely. And I think the big takeaway is how these guidelines, maybe more than ever, reveal the sheer extent of the knowledge gaps we still have in vascular surgery. That 70% reliance on level C consensus, it's huge. It means every single one of us has to be committed to transparent shared decision-making, really acknowledging the limits of our data, especially those persistent demographic biases in the original trials. The guidelines tell us what the consensus is, but critically appraising the evidence tells us why we often still face uncertainty.
Which leads perfectly into our final provocative thought for you, the listener, to mull over. We established that clear volume outcome relationship for complex aortic repair centers doing fewer than 20 complex cases a year are explicitly discouraged. So considering that undeniable link between volume and patient safety, how should our regional or national health policymakers ethically, practically justify continuing high-risk, complex aortic interventions in low-volume centers? Where does the evidence stop and the hard realities of healthcare systems and geography begin?
A question that will absolutely shape how specialized surgical care is organized or perhaps reorganized over the next decade.
Indeed. Thank you for joining us for this deep dive.